Okay, according to my clock, it is 3:03. So at 3:03, I'll call the meeting of the Seneca Healthcare District Board of Directors to order. Greetings. I hope you're all doing well. Let me take a roll call for members present. Jerry Nielsen,
Present.
Kristen,
Here.
and Dr. Walls,
Present.
and Rich Rydell.
Here.
And I'm Ken Crandall, and I am here as well. So keeping with tradition here, let's try the Pledge of Allegiance here. And I will lead that if you would join me, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, thank you all. That takes us to the third item on our agenda, which is the public comment period. I do have some people out here with phone numbers I don't recognize. So I'm wondering if members of the public would like to address the board. If you would like to do so, please indicate by raising your hand and give you an opportunity to make public comment, make comment.
And you can also address the board by pressing *6 to unmute your line.
I am not hearing anything, and I'm not seeing that folks have raised their hand. So with that said, we will move on to item number 5, approval of the board minutes from February 25th. So I'm hoping you've had an opportunity to review those minutes. And if there's something that you'd like to note, please speak up now.
Ken, this is Jerry. I'll make a motion to approve the minutes.
Second.
Was that you, Rich, on the second? Or
Yes.
Dr.
Yeah.
Okay. Dr. Walls?
I'm aye.
Right. Okay, Kristen?
Aye.
Okay. Rich?
Aye.
And Jerry?
Aye.
And I'll vote aye. Okay, thank you. So we have the med staff report here, and they're looking for approval of one initial appointment and one reappointment. The initial appointment is for Sonia Troxel, and the reappointment is for Adiko Kovacs. I guess that's correct. Should we take these one at a time? Let's go with the initial appointment of Sonia Troxel.
Yeah, Ken, I was just curious, can anyone speak to why there's an overlap in the time frame for the 30-day and the 2-year? I'm just out of matter of curiosity.
Can you hear me, Jerry?
Yes, I can, Joanne.
The reason for that is I wasn't sure when she was going to begin. So I wanted to be sure that she was covered. And that's why I put it for 1 month. That's usually it's 60 days, but I put it for 1 month and then everything was complete. So then I went ahead and did the 2 years.
Got it. Thank you.
So be sure that we're legal.
Sure. Thank you,
Yeah.
Joanne.
Okay, any other questions? All right, so can I have a motion to approve the initial appointment of Sonia Troxel?
So moved. This is Dr. Walls.
Dr. Walls,
I'll second.
second, Kristen. Okay, Jerry,
Aye.
Rich,
Aye.
okay. Kristen
Aye.
and Dr. Walls,
Aye.
and I'll vote aye as well. And then the second one is the reappointment of Adiko Kovacs. Forgive me if I'm not pronouncing that correctly. There's a reappointment from February 28th to March 28th, 21, or April 28th, 2021. So motion on that one.
So moved. Dr. Walls.
Okay, second.
Second.
I'll second. Sure.
Rich, I'll give it to Rich here. Okay, Jerry, how do you vote?
Aye.
Kristen?
Aye.
Okay, and Rich
Aye.
and Dr. Walls,
Aye.
and I'll vote aye. Okay, great. We have a number of policies and procedures here to approve, and then we also have some policies or procedures to be rescinded. So why don't we take these in steps? The ones for approval are 1 through 6 on your agenda. And I'm wondering if board members have questions about any of these policies.
I was only able to skim them. I didn't see any major changes, though. I don't know if Anne is on, if she could speak to whether there's anything. I mean, it looked to me like it wasn't, but
Anne, are
is
you-
Anne?
Well, I can tell you that nothing came up about these at the medical staff meeting.
Okay, thank you, Dr. Walls.
I have a curiosity question about LAC policy 041.110, which is the front office registration procedures. I'm not sure if anyone's online who can speak to this. I'm looking under section E, Medi-Cal. My question is, you see there's 1 and 2 under that, and it's if the patient has out-of-county Medi-Cal, they will need to see a provider in their county or pay for the visit as a self-pay. If the patient has special member status, this must be verified before time of service. So I'm wondering if somebody can just tell me what that's all about. I'm a little confused by that.
Well, Ken, I can tell you what the special status is, but patients who live in Lassen County, primarily Westwood, were already established with doctors, primary care providers in our clinic. They got special status so that they could continue seeing their primary care doctor.
Okay,
So those people are allowed to continue seeing them. And I have a whole bunch of patients from Westwood who are covered by Lassen County. However, they can continue seeing me because they were already established with me.
okay. So thank you, Dr. Wells. That helps. My other part is, let's imagine for a moment somebody's coming to Lassen County and they need to be seen because they're sick, Medi-Cal, Medicaid patient, and they do have Medi-Cal, but it's in San Diego County. Is there not an authorization process to allow them to be seen here and seek reimbursement from San Diego County?
Now, I can't answer that.
Anne is here. Can you hear me?
Yeah, we can hear you.
Okay, I just wanted to make sure. So we can get a prior authorization to see patients with out-of-county Medi-Cal. It generally does not happen in a day to get that authorization. And we don't always get the authorization. So we have it down that they will visit as a self-pay. Of course, we're not going to turn them down if they can't pay at time of service, but they at least have to sign a form saying that they realize they are responsible for charges if we can't get the authorization. If they do pay and we get the authorization and Medi-Cal reimburses us, then we reimburse the patient.
Okay, thank you. That's kind of consistent with what I thought might be the case, but it wasn't spelled out there. So I wanted to make sure that there is some attempt to seek an authorization from the county of residence.
Yes, absolutely.
Okay. All right. Thank you for that. Any other questions about the policies and procedures? Okay, then I would look for a motion from a member of the board to approve the 6 policies identified as 1 through 6 on today's agenda.
I'll make the motion. It's Dr. Walls.
Dr. Wallace, okay. A second? Do we have a second?
I'll second.
Ken, I will. It's Jerry.
Kristen does a second. Okay, Jerry, your vote?
Aye.
Okay. Rich?
Aye.
Okay. And Kristen,
Aye.
Dr. Walls,
Aye.
and I'll vote aye. Motion carries to approve those policies and procedures. And then we have some policies that are scheduled to, procedures, I'm sorry, that are scheduled to be rescinded. These are reflected as 1 through 5 on your agenda. Are there questions regarding any of these policies from board members?
Oh,
Not a
No.
one?
No.
All right, then I would seek for the, to rescind these policies, a motion to rescind them, to approve this.
so
So
moved.
moved.
Who was that? I got to, Rich, was that you?
Could be.
Okay, but was it?
I technically it was me and Rich is seconding, I think.
Okay. So, thank you very much. Dr. Walls?
Aye.
Okay, Kristen
Aye.
and Rich
Aye.
and Jerry,
Aye.
and I'll vote aye. So as reflected on our agenda, those policies identified as 1 through 5 scheduled to be rescinded. That motion carries. Got panicky there for a minute. I couldn't find the rest of my agenda, but I just did. All right, this takes us to item 8, I believe, on our agenda, which is the financial report from Steve. Good afternoon, Steve.
Hello. Okay, so we're looking at the month of February 2021, the 8th month of our fiscal year. For the month, we had a net income of $370,442 versus a budgeted income of $185,863, or a positive variance of just over $184,000. We unfortunately had a negative variance in total patient revenue, about just under 132,000, net patient revenue of just over 108,000. So that offset a positive variance that we had in our non-operating revenue. The HQAF 6 payment, supplemental payment, we had anticipated receiving about, as you can see there, $644,000, and we're actually going to receive $936,000. There's 2 parts of the HQAF. There's a part that we do through intergovernmental transfer, and then there's also a direct grant portion where we receive the supplemental payments without a intergovernmental transfer. That direct grant number came in higher than we anticipated. Of that 936 that we're going to receive in total, it's from our 2 managed Medi-Cal payers, and they provide us, each provide us 1/2 of that amount. We received one of the payments in February and hopefully receive the other one pretty soon. But we recorded the entire amount on an accrual basis, so we have a receivable for half the amount. The expenses for the month were great to budget. Our salaries, our labor costs came back in line in the month of February, where our salaries and wages were just under 24,000 over budget, but our contract labor had a positive variance of $36,587. So that's the alignment we want. We pay more for our contract labor on an hourly basis than we do for our employed staff. Everything is very similar to prior months. We provide the pro-fee medical expense in detail, the supplies relating to both COVID and some IV therapy and high dollar drugs that we purchased during the month. So overall, the expenses were positive to budget $8,000. For the month, our days cash on hand went up slightly from 131.9 to 132.4. There was a net effect of the operating loss we had, and then the amount, the HQAF money we did receive. We'll again hopefully receive the other half this month, the 25th. Haven't received it, so no guarantees there. We did, however, receive our fiscal year 2020 cost report settlement for just over $1.4 million and a lump sum adjustment for our rates for the year to date of about $500,000 for a total of just over $1.9 million. So again, our cash position, our balance sheet is extremely strong, and continues to help us weather the reduction in revenue, patient revenue during COVID and into this year. So we're just now, I guess Sean can talk about some of the things that he's been able to do and that we're doing to look at bringing the utilization back up. Any questions or comments or concerns?
Board members?
Yeah, Steve, this is Dr. Walls. Could you just explain to me again what the HQAF payment is?
It stands for Hospital Quality Assessment Fee Program.
Oh, okay.
And
Okay, I'm familiar
yeah.
with that.
Other questions? Well, Steve, thank you. That was kind of short and sweet.
Thanks, Steve.
All right.
Can I get a motion to accept the financial report that Steve just provided?
So moved.
Rich, right? Okay. Second?
I'll second
I'll
it.
second.
Dr.
Dr.
Waltz.
Waltz can second it.
Okay. Jerry
Aye.
and Kristen
Aye.
and Rich
Aye.
and Dr. Walls.
Aye.
And I will vote aye. So thank you, Steve. That said, let's move on to item number 9. This is the Association of California Healthcare Districts, ACHD, and our membership. I was a little surprised that our membership had expired. There's some trainings that are associated with belonging to the organization. I think we can get them for free, but probably not to the same level that we can as members. And I think it's a good advocacy organization for what we do and good resource for board members. So I'm hoping we can get a vote to renew our membership here. Questions?
Yeah, what does the membership cost?
Steve, can you tell us that?
And off the top of my head, it's about $8,000 a year.
Okay.
Other questions?
I'm wondering what Sean thinks about belonging to the association.
I think that at this time, especially around healthcare districts, critical access hospitals, rural healthcare, we need to have as much advocacy in this space as possible. There are so many changes occurring as it pertains to healthcare districts and some of the funding sources that are going on, some of the expectations around quality. So my perspective, Jerry, is that anytime that we can be involved and have advocacy and get the knowledge, we can glean knowledge from these organizations, it's worthwhile.
Okay, and then my other question is, I think we also used to belong to the California Association of Rural Health Clinics. And I don't know if we wanted, I mean, I guess that's not on the agenda, but I think that perhaps we might want to look at that again as well, or did we already?
Well, let's first establish indeed that our affiliation with them is expired.
Yeah, I don't know.
I would have to check that. I'm on their email list, so I get information coming from them, and whether they update their email list based upon subscription or membership, I don't know. Sometimes those lag. But we can certainly look into that for the board as well.
Yeah, so if we can, thank you, Sean, if we can just look at the ACHD today and re-agendize the CAHC membership for our next agenda to see what kind of recommendation you have related to that one, Sean? Okay, okay.
We'll check into it. Thanks.
All right, so I'm wondering if there's a motion to approve the membership for ACHD.
I
So
motion.
moved.
It didn't, who was first there? Kristen?
Doesn't matter.
Okay. Second?
I'll second it,
Okay,
Dr. Walls.
thank you. Jerry, your vote?
Aye.
Okay. Rich?
Aye.
Okay. Dr. Walls
Aye.
and Kristen?
Aye.
And I will vote aye, so thank you for that. The next item is our board meeting status, agenda item number 10. Some discussion on whether we should resume in-person meetings or continue with Zoom. Sean, I would really like your thoughts on that, but I'd also like to be mindful of, I think what I expressed the other day to you, Sean, was that I really don't know which of us as board members have been vaccinated and who hasn't been vaccinated. And I want to be cognizant that may be a large consideration for some people. So Sean, recommendations?
Well, certainly my recommendation is that there's always more accomplished face-to-face and with community input. So, but getting back to normal is a little bit tenuous at this time. The fact that we are in orange and I suspect potentially moving to yellow within the next couple of weeks. I'm going to defer to, is Stephanie on? Stephanie, are you available? I just want to ask you a question. Maybe not. Okay. You know, it's a very personal choice around vaccination. I think that some of us are still kind of wrangling with that, even though the vaccination for the vaccination quantities are opened up quite a lot, and that the phase 1C tier 1 was sort of underwhelming. That was the 16. We're going to talk about the 18 to 64 with underlying has been a little underwhelming. So we have vaccine available, you know, that is being distributed where it's not being taken up by that tier group. So I would love to come together. I understand, you know, the concerns for that. I would like to propose perhaps a hybrid solution for those that just don't feel good about it, for those that have been vaccinated and want to come face to face, and still providing a Zoom option until such time that we either reach a tier level that everyone's comfortable with, or everyone's been vaccinated throughout, you know, the spring and summer. So again, I lean toward wanting to get together again. I guess I miss it. I miss all your smiling faces and direct dialogue and commentary. But I want to be conscientious of the fact that we are not out of the woods yet.
So Sean, this is Dr. Walls. Now I'm under the impression that April 15th, they're going to allow any adult to get vaccinated. Have you heard that?
I've heard a lot of things, Dr. Walls. And Stephanie's not on. I think she's off today. I've heard a lot of things that, like I just said, the underwhelming response to the current phase and tier is causing the county to say, let's open it up more. I know that people are doing it on their own. There's a lot of people that are doing it on there just saying, they've got the vaccine, let's open it up to everybody. So I have heard that. I don't know that I've heard that officially. And we want to be good stewards of the vaccine, but at the same time, we want an inoculated, you know, we want a vaccinated community. But I can't confirm that. That's a long answer for I can't confirm that.
Other questions, board members? My suggestion here would be to, you know, follow what Sean has just indicated, and make it a hybrid and optional attendance until we are in a tier where the restrictions are greatly relaxed. Right now, we're still at, what is it, 6 feet social distancing, Sean? Is that right?
Yeah, so we're at orange, and I might get this wrong, so forgive me, but I believe it's 50% capacity in the space, whatever it'll hold, it's at 50% with social distancing and masks. Yes.
Yeah. So my initial thought and reaction to this is we just afford the remote option until we hear back that we're at minimum probably reevaluate it when we see what I'm not familiar right off the top of my head what the restrictions are in the yellow tier, but maybe at minimum to reevaluate it when we get there.
Okay. So, and I just want to, let the public know that is listening as we move into a hybrid. I believe we mapped it out. I took up my tape measure. I think that we can get 6 community members in the audience, and we can get 6 people around with our spacing, 6 people around the table,
Okay.
Possibly 7, but roughly 6 members of the community can join, and we have 6 chairs available. So it's going to be kind of a first come, first serve in the audience.
It's not quite the packed houses we used to have, right?
No, and yeah, I so look forward to those days again.
Yeah. Okay.
Sean, I've been texting Stephanie. She is off today, but she did reply that next month it would probably need to be something of a hybrid due to the fact of certain people needing to be present. It's very likely that it can accommodate the board members, but by keeping the 6-foot distancing, it may not have a whole lot of room for the public. The guidelines say 6 feet apart, but also that we have to, at this point, maintain half of the normal accommodation. So
Right.
at this point for the LAC, that would be a max of 15 people in the room.
Maximum 15. So yeah, okay. So 6 and 9. Okay, so 15 total is all we can do. So, okay, good to know.
I'm sorry, I have a dog barking in the background, so please excuse that. Well, that said, can I have a motion just to have the hybrid option available for us at our next meeting?
I would be willing to make that motion.
Okay, thank you, Dr. Walls. Can I have a second?
Second.
Thank you, Rich. Okay. Kristen, how do you vote?
Aye.
Jerry?
Aye.
Okay. And Rich?
Aye.
And Dr. Walls?
Aye.
And I'll vote aye as well. Thank you so much. That takes us to item number 11 and takes us into the information agenda. So we're done with the action items for the day. Item number 11 is the HRG Health Resource Group report from Steve. Steve, are you with us?
Yeah, I'm here. So we're looking at again, the report for the month of February. We finally got some movement and we're down to, we moved down to 67.5 days. We've had some very, very productive, if not unpleasant, meetings with HRG regarding the work they're doing, and we think we're solving some of the issues. Unfortunately, the answers we're getting are not the ones we were looking for regarding the status of outstanding claims, and more to follow on that. So short story is that I anticipate this number to continue to move down. We also went through the self-pay, and we have a large amount of self-pay that's gone through the cycle of collections. I think we discussed at the last board meeting, and we will start moving them on to bad debt and deal with that as it happens. But we're talking upwards of 5 days of AR that could be going initially with the self-pay, and more that's in the same cycle, similar amounts. So I think we're finally getting some attention from our partner. And again, unfortunately, it's exposing some things that were not done well. And I have a call with them tomorrow to discuss how we will address these from a contractual and financial standpoint. But
can I interrupt you there for just a second?
Absolutely.
I don't want to lose it there. You said things that were not done well, and I'm assuming you're referring to things not done well on their end as opposed to ours.
Yeah, the majority of it is on their end that, as we thought, based upon the way the numbers were looking and the lack of movement that we're getting on the older accounts receivable, that they just were not working those accounts. They went through and did a complete audit of all the long-term care accounts and have done a similar thing with the third-party hospital accounts, but they can't do the level of audit, the 100%, and they're finding accounts that there were issues with them, and they were initially billed, they were denied, or whatever was the issue, and then there was no follow-up, and now some of them have gone into an untimely filing status and will need to be written off. Some of the things they're finding is that there were errors on our part, but those errors were not communicated back to us, so we were not able to make the changes so that we get the bill resubmitted, and those accounts are also in an untimely status. So I think we've imparted upon them how we visualize the revenue cycle working, and that's not only to collect money, but to understand what we're not doing correctly so we can change our process, change our approach, retrain, whatever it might be, both their staff and our staff as appropriate.
Okay, thank you. That's helpful.
So you feel like, sorry, Ken. So Steve, you feel like they're not just trying to clean these up, but actually moving toward implementing process improvement so that we don't end back up here again.
Well, I'd like to say yes,
Hopefully.
but yeah, I mean, yes is a bit of a leap of faith, but I think the thing is that once we get to where these accounts are not just sitting there, we'll really be able to see when they slide out beyond the normal cycle of collection, and we can just be incredibly vigilant about demanding a response, demanding an understanding, and I guess maybe recalibrating our expectations of them that, you know, when something falls outside of the normal collection cycle, there better be an understanding of why and what. And I think that's probably where we've got them. We'll just see how it plays out.
Okay. Well, I'm impressed with how you guys are deep diving into this and figuring this all out, and it's greatly appreciated.
Yeah, it's good because I think the other thing is, you know, as we strive to provide a better patient experience, Sean shared with you that certainly there were issues raised with the patient billing, and so our ability to eliminate the things we can, healthcare is always going to be a challenge. I mean, the Mayo Clinic messes up on their billing, Banner messes up on their billing, so it's going to happen. But our ability to minimize that and be able to react to it is going to be a key to I don't know, to enhancing the patient experience. So it's really important to us from, again, two perspectives, and we won't let up.
Adding on top of that, the whole process is constantly a sort of a moving target. You know, it seems like it's always being moved a little bit, and just trying to get that rhythm and that pattern tends to be a little bit difficult in healthcare. You know, it's constantly things moving about, and you have to be on your toes all the time.
Okay. Steve, did you have anything to add? I kind of stopped and asked a question there and wasn't sure if we got sidetracked, or is there more you wanted to talk about?
Not that we need to go into at the board meeting, but I certainly am able to answer any additional questions or discuss anything deemed necessary.
Okay. Any questions from the board before we move on? Okay, well, thank you, Steve. Appreciate your report there. That moves us up to the committee updates, the Strategic Planning Committee, and I'm of the understanding that you met this week, so anxious to hear the report.
Yeah, so if I can lead in, but I would like some of the board members that are on the Strategic Planning Committee to jump in anytime here. Just tell me to hush and move forward. We did have our, what I consider to be an official strategic planning meeting with two members of our board that are on the committee. We met with our Critical Access Hospital Replacement Program Manager, Donna Huntingdale. Once again, this is the person that has been brought on to basically drive this process all the way through the phases and keep not only ourselves moving, but all of the vendors associated with the strategic planning moving in the right direction, follow-up, action items, timelines, and such. We discussed many subjects related to the master planning. Meetings will be ongoing. I'm not going to go into a lot of detail, but I would certainly like either member of the Strategic Planning Committee, they're on the board of directors, to add to that. This does have momentum. It is going to continue. So I'd like to just open it up for other reports from the members of the board.
Rich, anything to add to that?
I just add that I thought the meetings were very productive, and I really think for the first time in a long time, I think we're moving along and moving in the right direction.
Great. Jerry, you're the rep, am I correct?
Yes, I am. And I greatly appreciated our new project manager, Donna. I think that she did a wonderful job, and I was impressed with her follow-ups after that, making sure that everyone knew what their action items were and their takeaways. And so as a project manager myself, I could see that she's definitely going to help us out a lot.
Oh, good. Well, sounds like a good call, Sean. So thank you.
Great deal of trust with her. Yeah.
Yeah. All right. If there's nothing else, we'll just move on to your report, Sean, the Chief Executive Officer report.
Sure. I like to lead with C19. I'm going to stop calling it COVID. We're going to make up a code name for it. So it's Coconut 19 for this board meeting because I'm tired of saying COVID, but let's give the report. Seneca Hospital and Lake Alamo Clinic continue to remain COVID-free. We continue surveillance as necessary per the county or internally. We are open, and are constantly diligent. I just want everyone to know that. The vaccinations are continuing. We've had great success in our vaccination clinic. I want to throw a lot of kudos out to the staff that are preparing this and doing the work in our vaccination clinics. I can tell you it is like a Swiss watch. It continues to just go really well. A lot of compliments from the community, so I appreciate the community's input. We're doing everything we can to put vaccinations in arms in the most efficient manner possible. We're currently working under the guidelines of Phase 1C Tier 1, which is ages 18 to 64 with underlying health conditions. Dr. Walls brought up the fact that there may be some changes to that because, again, that has been a pretty underwhelming grouping or tier where we don't have a lot of participation. So we do believe that there's going to be an opening where the vaccinations become pretty plentiful. We need to not waste it, and we need to open it up a little bit more. There is a lot of discussion around that. We have plenty for primary and secondary doses, so there's no worry about running out. Sure.
Can I ask a question on that? It was my understanding it wasn't 18 to 64 with underlying health conditions, but also certain workers from, I think, food service, restaurants.
Agriculture, food service.
Okay.
The county is doing those injections. They want them to go to the county for those.
And what about, so at the clinic, we're doing our own? It's not all administered through the county now? I think I'm confused there.
It's distributed through the county to us based upon the numbers that we have on our list. And then we've had our vaccination clinics actually at the Chester High School gym. Okay. It provides a way better venue, a lot more open space. So we get it from the county and then we put it into our community.
Got it. Okay. Thank you.
There are some worries along those fronts. The state of California, it's interesting, us as healthcare workers and healthcare providers in the community just want to protect our community. And unfortunately, this is for information only, but it gets caught up in a lot of bureaucracy. And there is no lack of bureaucracy right now. As many of you might have heard, Blue Shield has been assigned or been designated as the third-party administrator, the TPA, for COVID control, COVID distribution, and such. They have laid in so much bureaucracy into the methodology around just getting the vaccine in people's arms, that it's just unbelievable how much layering can happen. I just want you to know that they want us to move to a new scheduling system called MyTurn, which our spreadsheet and delivery was going great, but now we've got to do this MyTurn thing, or we're supposed to. Blue Shield is saying that under the MOU, as the third-party administrator, they want us to build an interface for reporting into this system that they have. It's an unfunded mandate. That's anywhere from $7,000 to $15,000 for each facility to create this interface. That no one's really come up and said, hey, we'll give you the money for it. It's just part of this memo of understanding, and I can tell you, I've been on several CEO calls, and this is just, people are not signing the MOU. They're just basically, there's a little kind of mini COVID revolt going, saying, listen, we report it, and we report it as we do now. Give us the juice and stop laying all this bureaucracy. I just want the board to understand that there's a big pushback against all of this, against the state getting in the way of us getting into vaccinations into our community. So we're fighting the political fight on this one, and it's really unfortunate because we're just trying to get it into our community, and they're just layering it up. I want you to be aware of that has not gone away. I can tell
Sean,
you.
is this something that you need your board to write a letter to someone about? Is it that kind of a level of an issue?
Not yet at this level. The county's actually kind of taken the initiative to push back a little bit, because they're checking with us to a certain degree, but not yet. I can tell you that some of the larger facilities have their boards members have helped them push back. Right now, I'm gonna kind of see how it goes, Jerry, because I believe that there's a lot of pressure on the state, and there's a lot of pressure on Blue Shield as the TPA to get out of the way, and let this work. And it's been working great. We just need to stop layering bureaucracy at this point. But I'll let you know if I could use a letter. I'll tell you that.
Yeah, definitely, or phone calls. I'm happy to make calls too.
Great. Doug LaMalfa.
Yeah.
That's our guy.
Yep.
Let's go to physician and mid-level recruitment and retention. Medicus, the firm that we hired, the one that I've used in the past, have submitted multiple vetted resumes to us. Currently, they've submitted 4 physician candidates for our review. We have conducted 4 phone interviews for the 4, and we've invited 2 for visitation to take a look at us and our medical staff. Those that I thought just had a great personality and were really looking for this type of work and can become part of our community. So we're going to be inviting 2 to visit us. One of them is scheduled for the first, Chelsea, if you're on, it's for the 5th and 6th of April, a Dr. Calvin Ruiz. And we're working on Dr. Kazumi Yoshinaga. Fantastic interview with her as well, to take a look, and we'll be setting her up as well. So there's that. There's some nurse practitioners. I'm being a little more particular about that. We have a lot more resumes that are coming in for that. But we're just taking a look at our mid-levels as well. So I'm pretty optimistic at this point. Obviously, the biggest thing is to not oversell the location. We're not Tahoe. Let's not oversell it. So we've been very, very forthright and honest about where we are, both in our transition as an organization and what our needs are to the community. So I'm encouraged. We're rolling out the carpet for these physicians, not because we have to, because we're beautiful and lovely and all that, but we want to get the best impression going on. So that'll be happening through the month of April and probably early into the month of May. Any questions about that?
I
Questions?
think that sounds great. Where are they currently practicing? Are they California physicians or elsewhere?
They're all getting their California. One of them is from Southern California, and the other one has done her residency in North Carolina. So she's currently in North Carolina. The other person is in Meridian, Mississippi. But they're all, it's interesting, they're all California natives, all of them. And some of them know the area quite well. So
Fantastic.
it's good. I'm looking forward to meeting them. And I'm sure the board will be as well. Let's see, that's going, and we're excited about that. Existing facilities upgrade. So we have had an unbelievable response to our bid, our RFP that went out for our roof. Instead of having one vendor, we have, I think Linda McCurdy said, up to 6 or 7 vendors that are looking at bidding on the work for our roof. And there's going to be a job walk coming around very soon, so they can take a look. That's a requirement of the re-roofing. Very excited about that. And frankly, our painting projects, our campus painting, we've had multiple vendors are looking at that as well. And some of those job walks have begun. Bidders are completing the job walks. Linda's facilitating these with the vendors. We did select the vendor to provide the install of our security cameras on campus. The vendor will be conducting a job walk tomorrow as part of their initial phase of implementation. Linda's also will be also facilitating that. They'll begin their work shortly after the job walk. So we will be getting our cameras in place. And I want to thank the auxiliary publicly. The auxiliary has provided funding toward that effort, and I want to thank them for this. It's not a small amount, but they have come forward with a great funding option for us. And I appreciate that, and several other things that they're doing for us as well. Campus cleanup is continuing as we work to declutter. You can see we have another big trash, I guess a big dumpster. Yeah, that's it. Thank you, Renee. A big dumpster outside, and we're picking away now at the train car. The upstairs that was completely cluttered, you can walk freely, you can jump rope, you can do all kinds of things up there now. So we're excited that our declutter effort is working. You'll notice if you walk in the hospital that you don't see as many things hanging on walls or in windows or doors with tape. We're de-taping, we're taking thumbtacks out of walls. So pretty excited about how she cleans up. She's starting to look really good. And I think that the community is going to start seeing a big difference in the way that our physical plant presents itself.
I wonder if, sorry, Sean, I wonder if Collins might be interested in that train car for their museum.
For the whole public and anybody who's on this, if you're interested in the train car, we have them. And we'd love to give it to you. You have to come pick it up though. I will check with Collins. I think that's great. I don't know that it's quite vintage enough, but that's a great idea, Jerry. So we'll reach out to Collins and see if they want to put it there in their museum.
Hey, Sean?
Yeah.
I think that Collins was involved in putting the train car here in the first place.
Dr. Walls, would you like to call them and see if they want it back?
Well, I know we used one of their loaders to move it into place, and they have the equipment to move that thing. And I'm sure they'd be willing to help with that.
Okay. Well, when we get it cleaned out, and we can't get rid of it, you might see me out there with a cutting torch and loading it onto my little pickup, but piece by piece. But
can I ask you another question that I just thought of now? You're going to put a new roof on the hospital?
yes.
Who has decided what color it will be?
That's a great question. It hasn't been decided, but it's all about the paint schema, working with the roof, and we want to move our colors more into the blue spectrum, as we did with our logo. So we're talking about something more neutral on the roof. I am the last person you want to talk to about colors. So we are going to employ those that have a better eye for this. We have not decided on any of that at this point. It will be metal. It will be a hidden seam, I think it's called, or something like that, where you overlap and you don't have a bunch of bolts and stuff and things looking out. But so that's to be determined, Doctor. We'd love to have your input.
Okay.
Any other questions about existing facilities upgrades? Trying to be cognizant of the budget, trying to do these upgrades while we're keeping an eye on the new build and what that's going to take. So we're trying to be prudent as much as we can, but we have to be here for at least the next 5 years if we do a really great job with the new critical access hospital and build. So we need to prepare for the next 5 and for whatever's after, however she's repurposed in the future. Okay. Any questions from the board? Okay. Moving into operations, a little bit of a shorter report today. We held our 3 mandatory staff town halls the week of March 8th. These meetings were outlining the changes that we'll be undertaking as an organization with expectations related to our work and the overall future of the facility. I was pleased that we did have a couple of the board members join us, and thank you for joining us. I think that the message was delivered clearly about how we treat each other internally, how we act professionally, and how we work with our community. We are going to literally be having a different philosophy about the way that we do our work, building with positive intent. Thank you, Ken. Moving into an entirely different look. You know, the biggest thing is we will be the friendliest place in Plymouth County, period. Good medicine, good experience. Jerry or Kristen, do you want to share? You were both there. Do you want to share anything from the town hall?
Kristen, do you want to go first?
I can. I thought it was amazing. I definitely think everybody got the point of working together and trying to be positive, and what the goal is. That's what the end goal is, of everybody being more cohesive. And I definitely think it was received very well.
Yeah, that was the impression I came away with too. I think Sean, I think you did a wonderful job of outlining the expectations and giving everyone a sense of purpose and hope and a way to move forward and help improve the work environment as well as the customer or patient experience. And I think that it went very well.
And that's really critical is our community, we want our community back. We want our community to trust us with their care and have a good experience. And that is what we're working toward aggregately together, all of us. There's not one piece that's going to be left out of this. So,
John, any plans for, repeating the process quarterly, annually? I don't know what that looks like, but any thoughts on that?
Well, we're putting up little reminders everywhere, which I haven't even spoken to Chelsea about, but we're going to be putting reminders about, just a reminder. But yeah, I think that this is something that is a constant sort of reminder. It's a heartbeat, right? It's just something that we have to work through, and a constant awareness of how we work together and work with our community. So yes, it's not just the one-hit wonder. It will be a constant reminder. And a real-time reminder as we see good things happening in the organization with the staff, as they present really good things, it's recognized immediately. And I want to really work toward that. And of course, things that are kind of retrograde or against some of these philosophies, those are caught as well, not in a punitive way, but in a reminding way to say, let's move the ball. Okay. I want to interrupt just a second here. I just got it hot off the presses. California will open vaccines to everyone 50 and older on April 1st. And April 15th to everyone 16 and older. So hot off the press.
That's the same thing that I mentioned earlier. I thought they were going to open up to everybody, every adult.
It's just been put over the wire, Dr. Wall. So you're rubbing your crystal ball, and it's exactly right. Appreciate it. The last thing is marketing and public relations. The only updates on that, other than our rebranding efforts, and there's going to be a lot of changes in our rebranding, from letterhead to our sign out on the hospital to in Plymouth News. I mean, there's going to be a lot of things that are going on as it relates to our rebranding. The rebranding has been met with very positively. The community likes it. The staff really like the look and such. The biggest thing is the community forums that was going to be spun up by the Chamber of Commerce. Looks like they're working toward getting those rolled up in May. Obviously, it clearly depends on whether or not we spike back up or not. I don't think we're going to, knock on whatever piece of wood you have nearby. But the community forums, I've already asked for a seat on every single one. I think that I want the community to be able to ask hard questions, and I want to be able to give them the answers and the directions that we're going real time. So looking forward to that.
Thank you, Sean. It was a pretty upbeat, positive report. Good to hear. So, departmental reports. We received reports from Chelsea on compliance, received a report from Ann on the clinic and telemedicine, and we received a report from TK and from Jim Kooiman. So if you've had a chance to review those and have questions, now would be the time.
Yeah, I have a question for Jim. Is he here?
I believe he is. Jim, are you with us?
I am.
On
Can you hear me?
on your report for the physician assistant for the clinic, it says they're full-time, but my understanding is she was going to be part-time.
Yeah, I should have put part-time on that, Doc. She's starting off as part-time.
Okay, that's all.
Okay.
Other questions?
And I greatly appreciate the reports. I just had one quick one for TK if she's still around.
I'm here, Jerry.
Hey, TK. I was
Hi.
just curious, you were talking about transitioning over to notes. Do you know when that's going to occur?
It's in process now. As far as I don't have a time frame on each of the previous documentation applications from Evident. The one that we know of right now is called PhysDoc. That's the one that actually will be sunset in June. And currently that's the one that the ER physicians use. We do know that we have the issue with the notes filter. We're doing our best to put reminders in that documentation tool for the providers so that they're adding pertinent information via the Dragon tool. But we are actually and actively transitioning those physicians now. My goal is, even though it's June, we start to pick up in May, and I would like them to be fully fluent and comfortable in the application prior to our visitation season. So we are actively doing that now.
Thank you. That's where I was going with that. You read my mind.
Yeah, in the last week to two, we transitioned one. For 2 additional physicians, we already have templates built. We just need we want to have their feedback before we actually make it live and in use. So with the prior physician, he literally was live same day.
Okay.
Of
So
course,
we're going to run these parallel. We're going to run them at the same time. Both notes applications are going to be live at the same time.
They are. The notes and the PhysDoc are accessible at the same time. Now, I just want to be clear so that everybody understands. So this is not what's called ClinDoc, and I'm kind of using some old terms in regards to what Evident might be using now, but I'm doing that to be able to draw the distinction. This is only happening within the ER environment. They have not given any specific dates or time frames in regards to ClinDoc, which is what we're using in the clinic. But their general focus and their movement is towards notes. It's just that we have the deadlines for the ER department specifically at this time. We are trying to introduce the doctors to notes in all areas, though. There is a greater level of success, a familiarity. It improves workflow for all departments if we can get all doctors on one charting application. So that is our end goal. But again, we're doing it in a way that hopefully is successful for the physicians, but is also, again, we want it safe for the patients. With those filters not quite working like they're designed, it is an area of concern. So that's why we build internal workarounds, flows, cross checks to try to catch anything that could possibly be missed.
Okay, thank you. And then the network assessment, that's when we do annually, right?
No, well, we do a network assessment annually. I think the one that you're thinking of is the penetration test.
Okay.
It's a more in-depth network assessment. That is biannually. That is one that will be due sometime this year, but that is not the one that's listed in the report. That one is more of an overview. So as I've been evaluating things, I've been discussing them with Sean. I just have some things that I would like to have a little bit more of an in-depth review. I want to make sure that as you see in my report, for the security, reliability, and sustainability, I want to make sure that we are equivalent with the industry standards for our field. And so we did interview the 4 companies. They all presented well, but we felt that this company, they have more of a foothold in the healthcare industry. They seem to be on par with what we were looking for, and as far as quality and detail and deliverables and all of that, actually for a very comparable price. So this is the one that was awarded this assessment, and we are very much looking forward to their findings. We're very excited about where we're going and how we want to position ourselves for the new hospital. Of course, we want to maintain the high security that we have over the years, but I do believe that we can bring a higher level of functionality to our end users.
Always room for improvement. I'd be interested. I mean, I don't know if you necessarily would want to provide in-depth details, but I would be interested in an overview of the outcome of that report. I don't know if the other board members feel the same.
Are you suggesting we add this to the agenda?
I'm suggesting that once the report is complete from this company, that maybe TK can give us a summary, kind of where we're at, where we're going. It doesn't have to be, rolled down in the weeds, technical, just kind of here's how we did and here's what we're doing, kind of overall
Absolutely.
To improve things.
Jerry, I do have one request though, due to, I forget if it's called trade secrets or quality or whatnot. I would request that I be able to present that in closed session. If there is anything that I need to share with you that's of a sensitive nature or an area for room for improvement for security purposes, I would feel much more comfortable if that's in closed session, so that way I can be transparent.
Yeah, I fully agree with you on that, TK.
Okay, TK, thank you. Any other questions for TK before we?
I do have one item to add. It wasn't agendized, so I just would like to just update you on it. We were working on the medical staff policy and procedure for abbreviations, which we have looked at the evident templates rather. But we're actually going to send this back to medical staff. I believe we might be able to do this in a more concise way that eliminates having to bring this back to the board on a frequent basis. Rather than listing all approved abbreviations, I think it would be more efficient if we specifically listed exclusions and then potentially us saying that our abbreviations will follow the guidelines of, and then have medical staff choose what guideline that they want for approved abbreviations. That way, if there's a new term that's used next month, we don't have to keep bringing this back to medical staff and board and committee for approval.
That makes sense.
Okay, TK, thank you very much.
Thank you.
Yeah, thank you.
Okay, I think that takes us up to item 15, which is agenda items for next month's meeting. And the only thing I had noted here was that we probably want to bring back our discussion about our meeting schedule. And then I had a note here about joining, I've forgotten the acronym, CAHC. And other than that, it would be our pretty much, I believe, our standard agenda. Suggestions?
I think so.
Okay.
I think that's it, Ken.
Okay, very good. That said, Sean, we're about ready to move into closed session. I noticed as I looked at the agenda here, we have, there we go, 3 items for the closed session. I know Jim needs to be here for the 3rd item. I'm assuming it's just you for items 1 and 2, Sean?
It is.
Okay, let's do that. Let's leave Sean in the room, TK, and we'll close the session to everyone else and let you know when we're ready for Jim.
Okay, I'm going to stop recording now and I'll place everybody in the waiting room except Sean. Thank you.
Just let me know when you're done, okay?
Okay, will do.
Thank you.
Okay, can we have resume recording?
Okay, thank you, TK. Appreciate your help. Okay, the board has concluded its closed session and now we are resuming our open session. The report from the closed session is that the board has voted unanimously to approve the labor contract as ratified by membership, administration, and the union. So I believe that concludes our business for today. Our next meeting is on April 29th at 3 p.m. It will be via Zoom. And we will, I guess, see you on the 29th.
It will be Zoom. Are we going to do a hybrid? I just want to-
Hybrid, I'm sorry. Thank you, Sean. It will be a hybrid session where some people may participate in person.
At the LAC.
Others may choose to be on Zoom. Okay. All right. Meeting adjourned. Thank you all.
Thank you.
Thank
Bye
you.
now. Bye.